Hi, I'm Dr. Russell Friedman, and today I'm going to talk to you about QSM3 and how to set somebody up from the right side versus the left side, because as you know, there's many times that we actually have to turn somebody over to address something like a head tilt or a decompression or so forth. So it gets confusing. We're talking about the up pelvis and the down headpiece and so forth. So I'm going to run through two scenarios with the same numbers. One side is up, right side up, and the other side, well, the other one is going to be left side up. So in this scenario, I have a right half-inch short leg, right 22 pounds, posterior 7 of the pelvis on the right side, right 2 of the fixed point, and this is what we use as a stick figure in the office, is a right bow with a left head tilt. So in this case, we're going to have the right side up. Why? Because of the bow. The headpiece is down because we're going to decompress to elongate the person and create a tractioning, which is going to do this. Okay, the quadrant that we're going to close, because we're dropping the headpiece down, we're going to close the left anterior quadrant. Why left? Because we're dropping it. We're dropping the head. So when we drop the head out, we're contacting, we're accessing, creating a closed kinetic chain on the downside of the patient. So where is the pelvis on the downside? Well, the upside is posterior. So the downside must be anterior. That is our access point. That is where we're going to send the force around, the energy around. It's going to go A to P on the left, and it's going to go left to right. Okay? The up pelvis. Okay? The up pelvis, okay, so now we're going back and forth, down, up, that kind of thing. The up pelvis is the right pelvis, and it's posterior. So we're going to push it P to A, and we're going to traction it to get that tensegrity, to allow that energy to flow more appropriately, okay, with least amount of force. And then what we're going to do is actually, because we're pushing it P to A, is we're creating that mirror image and that proprioceptive impulse into that bed of mechanoreceptors down in the pelvis that say, here, 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 this is the new place. As we contact up here in the upper cervical area, that says impulse to mechanoreceptor, mechanoreceptor. So we're affecting both of the largest mechanoreceptor beds. The next thing that we look at is leverage, okay? The leverage is, we're talking about the side that's up, because that's the side we contact with our hand. So the contact side, which is the up side, which is the right side, because of the right bow, is P to A. Why P to A? Because the pelvis is P here. So we go P to A. Why I to S? Because we're going to lift, okay? And then the torque, though, is because we're sending the force around, okay, the torque is superior because an anterior pelvis, which is the left side that we're dropping out on, that we're contacting, is the torque is superior for an anterior pelvis. Okay? Let me show you what that looks like, and then we'll just flip the person over and do it all over again. Side up, which means because we have a right bow, we're going to drop the headpiece down. And how far do you drop the headpiece down? Just enough to create contact on the left side. So I lift, connect, and drop it down, and then bring this support back up to create some support here. The edge of the occiput is on the most inferior aspect of the fixed support. You do not want to head all the way up where the fixed support is sitting on the atlas. All right, so we've got the head down, which means we're creating a closed kinetic chain on the left side. Where is the pelvis? Anterior. So we tuck the chin here. All right, the pelvis on the right side is the one that we push. This is posterior on this side, so we're going to push this forward. Okay, so now we have P to A here. We have the head down and the head tuck, so we have the left anterior quadrant as the force comes down. And as I come in, I'm going to go P to A. Why P to A here? P to A because the pelvis is posterior on the right side. So as I move posterior, the atlas is set up, it's tipped like this. The atlas is connected on the left side. So as I come posterior here, I'm coming anterior on the other side. All right, and that's what I'm checking is the anterior pelvis. So P to A here, I to S here, and what's the torque that I use? Superior torque, superior torque, superior torque. Why superior torque? Because superior torque is the anterior pelvis on the other side, and that's where I make the connection. So where I access by dropping the headpiece down, that is what I need to know where the torque is. Okay? Now we're going to flip her over. Come on up. Okay, so this was the original misalignment. Right a half, right 22, posterior 7, right 2. Now I got her on the anatometer, and I noticed that she's right 6, posterior 1, right 1. This is her configuration, though. She's leaning to the right, and she's head tilt left. If you notice, the rotation is almost completely out of there, so I have decompressed her. So what is the next phase? Next phase is look at the skull. The skull is tilting left. So we're going to put her left side up, drop the headpiece out. When I drop the headpiece, I'm setting up an access on one side because she's left side up. Dropping the headpiece sets an access on the right side. Where is the pelvis on the right side? It was originally posterior. It's still a little posterior. I always stay with the original number, all right? So right posterior quadrant. So we'll drop her head down, lift her chin. The up pelvis, we're going to, which is the left side, okay, left side's up, is going to, it's anterior, so we're going to push it anterior to posterior. The leverage points are then, the leverage points are where my hand goes. That's the way my wrist lever goes. It's going to go A to P because I'm left side up, and the pelvis is anterior on the left, so A to P, I to S to get the head to turn over, and the torque is what? The torque is the way that the force travels down the closed kinetic chain. Where is the closed kinetic chain? It's on the right side. So I want to know where the pelvis is on the right side. Where is it? Posterior pelvis on the right side is inferior torque. So I've got an A to P and an I to S with my wrist lever, but the torque is where I access on the closed kinetic chain, and this is what it looks like. Okay, so we've got her left side up. All right, I'm going to drop the head, lift the chin, I lift and I connect. I close the kinetic chain on the other side. So head is down and it's connecting on the left side. I am lifting the chin, so I access the right posterior quadrant. This pelvis here is anterior, so I move it posterior. That's the up pelvis. And I do this and I hold this here and I traction. Watch how I traction this. I'm not pushing here, I'm stabilizing, tractioning this. Then what I'm going to come in is I'm going to come in LA, okay, YA, because she's anterior on this side. The pelvis is anterior on this side. And as I come anterior, what am I checking? I'm checking the posterior component of the pelvis on the closed kinetic chain. So the head's dropped, I'm sending the force anterior, which is as it moves, it's checking posterior to anterior on the opposite side. So it's anterior to posterior, I to S, okay? And it's inferior torque, okay, because of the rotation of the pelvis on the down side. So it looks like this. Here, A to P, A to P, A to P. I like to shift, I to S, I to S, I to S. Torque. I'm just going through the motions here. And then we give her a check, and then we'd see where she is. And then we look at the frontal plane. If she's still leaning off to the right side, I'll come on with a right side up, with an up head piece, tap it a couple times, set it to center. If she's on the left side, I'll probably leave her there because she went 22. She originally started with right 22. Clear out the rotation. Clear out the rotation of the pelvis, okay? Then clear out the skull, then clear out the frontal plane. I'm Dr. Russell Freeman.